ICFRC hosts community programs to address topics of international interest, and we thank our members, volunteers and interns for making these forums possible since 1983, the year when 2 separate research groups identified a new virus that was responsible for infecting people with HIV/AIDS. That's a different one for you. I want to acknowledge our university and community supporters. The University of Iowa's international programs, the University of Iowa's Honors Program, the University of Iowa Center for Public Policy, and the Stanley UI Foundation Support Organization for their financial support. And I thank today's special sponsors, Mason K. Braverman and Mike Carberry. I also thank City Channel 4 for professionally recording our programs for cablecast on City Channel 4 or 118-2, and UI Library's digital archives. It's my pleasure now to introduce Ashleigh Wallace and Eesha Patel. Eesha is a second-year student at the College of Pharmacy. She was born in London, England, spent her formative years in Nairobi, Kenya, prior to moving to the United States. She received a bachelor's degree in psychology from the University of Iowa, and she currently volunteers in the emergency room as a student pharmacist, where she has the opportunity to interact with patients from many different demographics. Ashleigh Wallace is a third-year pharmacy student at the University of Iowa. She originally from Northeast Texas, completed her prerequisite education for pharmacy at Iowa State University, and is currently working on both a Global Health Studies certificate and her PharmD. Her professional interests include working with underserved populations abroad and providing healthcare in low-access areas. Today, Ashleigh and Eesha will focus on different perspectives and experiences from a summer spent in Sarigor, which is near Mysore in South India. Over the course of 8 weeks, they contributed to several projects that were centered around different areas of healthcare and allowed both students to broaden their outlook as future healthcare practitioners. Please join me in welcoming Ashleigh and Eesha.
Hi, I'm Ashleigh.
And I'm Eesha.
And we just want to thank everybody for coming out and wanting to listen to us talk about our internships in India from last summer. So the outline for today, we're going to start off with some historical context, and we're also going to give you some geographical context as well. We will talk about how the Swami Vivekananda Youth Movement fits into this context. We'll also talk about our projects. We'll continue with cultural experiences, and then we'll wrap up with the lessons learned from our internship. So the history of tribal populations in India. Currently, there are over 3 million tribal peoples in India. They are the original inhabitants of the forests in India. They've been there for generations. They've moved freely within the forests. This is where their sacred places are. This is where their culture and tradition is from. And they are primarily hunters and gatherers. Throughout time, as Europeans moved farther east, in 1865 specifically, the British created these colonial forest laws. And what this did was it restricted timber, plant life, and wildlife, mostly for the use of the British colony. And so those types of things were regulated. In 1927, they had the Indian Forest Act. This further restricted use of these types of commodities. It also restricted movement throughout the forest. So the tribal communities are very used to moving around in the forests. This act restricted that movement a little bit more. After independence, in 1972, they had the Indian Wildlife Protection Act. This ended up forcing out all of the tribal communities from their original homes in the forest. This was meant to protect the wildlife and the plant life in the area. And environmentally, it's a great idea, but it forced all of these people out of their sacred homes, their traditional and cultural homes. As a way to make up for this, the government created an incentive. They said that if the tribal populations want to voluntarily and peacefully move out of the forest, they will provide housing with electricity and water. And they will also give them land to cultivate. But remember, they're hunters and gatherers, so they are not traditionally agricultural peoples, and so they had to teach themselves how to do these things. And this was only 30, 40 years ago. And one thing to keep in mind is that the tribal perspective was largely ignored throughout this whole process. So they were never consulted and considered in any of these decisions, and they have been isolated and ignored this entire time. This is important to consider because the organization that we did our internship with was created to address the needs of these tribal populations.
So the Swami Vivekananda Youth Movement is the organization that was created, and it was inspired by Swami Vivekananda, who is on the left pictured, and he was a spiritual leader in India, and he was best known for his work to empower the poor in society and for the betterment of society. Dr. Bolu, or Dr. Balasubramaniam, on the right, has visited Iowa previously, but he formed the organization with a group of medical students, and it was previously headquartered in Surgur. It's currently headquartered in Mysore, India, and the 4 tenets or principles of the organization are listed above. They are Satya, or truthfulness, Ahimsa, or nonviolence, Seva, or sacrifice, and Seva, which is service, and Tyaga, which is sacrifice. So, as Ashleigh stated previously, the organization is focused around empowering the tribal population, and there is also a mobile health unit that is very well connected with the organization, which houses a hospital and a school system, and the mobile health unit goes around to all of the different locations and helps empower the population. So, as I alluded to previously, the mobile health unit serves over 40 villages around Surgur area, and they conduct many different health checks and screenings, and they provide primary care. So some of the primary care services that are provided include blood pressure checks, and then basic medication prescriptions for mild infections, pains, and aches, and then antenatal care and postnatal care is also provided. So this is for pregnant women, and what it is just caring for the women throughout their pregnancy and then post-delivery, and caring for the infant children as well through immunizations and vaccinations, which are huge, and they have taken a big program and really promoted that throughout. And then another new initiative that was started while we were there was hemoglobin checks, because anemia is very prevalent in that area. And if anything cannot be treated on the mobile health unit via primary care, referrals are made accordingly to other institutions or the Vivekananda Memorial Hospital Institution, which is affiliated with the mobile health unit. So the schedule for the mobile health unit, it runs every Monday through Friday, and it visits the same set of villages every day of the week, say about 7 to 8 villages per day, and it would visit the same villages, every Monday on a repeating basis for continuity of care.
So to give you some geographical context, if you look here on the southwest, this is the state of Karnataka. Karnataka is where Mysuru is. Zooming in a little bit more here, you can see the small red dot of where Mysore is, and this is where the Vivekananda Institute of Indian Studies is. Mysore is home to about 800,000 to 900,000 people. It is considered the cleanest city in India, which was really interesting. The general headquarters of SVYM are here, so they have their main office, they have their Indian Studies program. This provides a master's degree in a couple of different areas, so Indian students come here and they finish this, or they complete this degree. Additionally, they have dorms for these students, and this is also a place where international interns can stay. And one of our colleagues actually did her project here, and they focus a lot on education and political advocacy.
So the other 2 centers outside of Mysore are Surgur and Kanchanoli. I previously talked about Surgur. That's where Ashleigh and I were stationed, but Surgur is a small rural village, and it houses the Vivekananda Memorial Hospital as well as the Viveka School of Excellence. And it also is this base for the mobile health unit. So the Vivekananda Memorial Hospital is where secondary care is provided. They have very state-of-the-art, surprisingly, equipment and facilities for, the location. And they also have the Viveka School of Excellence for all of the townsfolk. The school is for kids aged 3 to 18, and education up to 12th grade is provided. And then Kenchinelli is another village, and it's more of Ayurveda care and research that is conducted there. And there is also a school there, more so for tribal kids, and it's more of a boarding school. Kids are brought there at the start of the year, and then they stay throughout the year. Alrighty, so the next few slides will center around my experience and the projects I conducted while I was there. So I'm just gonna get started with that. The first 3 series of projects I conducted were had to do with the mobile health unit. So the first one was the revision of the mobile health unit manual. So this manual just centered around what the mobile unit does, the protocols, and if anyone wanted to come in and see how to respond to a certain situation, they could refer to the mobile health unit. And the second set of projects I worked on were the standard operating procedures. So prior to this, there were no standard operating procedures, which would highlight protocols and more extensive explanations for what to do in certain situations. Those were used more by the attending physicians or support staff on the mobile unit, and they could be used while you're on the field or once you're back at the headquarters. And then the last project was actually a really fun one. And I had the opportunity to design a brochure. So for fundraising opportunities, I really got to bring out my creative side for that one. And I was given a week to do the project, but I ended up getting really excited and doing it within a day. My mentor was very happy with that one, and it came out pretty well. So that was really fun to do. The next set of projects that I worked on were the basic life support and the code procedures. So a code is the way of rapidly alerting people onto an emergency situation that is occurring, a medical emergency, basically, in the vicinity. And a gap analysis is a comparison of what is being done and what needs to be done ideally. So my project was to basically conduct the gap analysis onto code procedures. So what I ended up doing was I interviewed different staff members, residents, attending physicians, nurses, and support staff in many different units of the hospital. And then I talked to them about what they were doing when a code was occurring or an emergency situation. And then I documented all of that. And I also compared it to what should ideally be done. And I documented everything I found on both of those things. And then I made recommendations. One of my recommendations was providing basic life support classes or workshops on a regular basis to keep everyone up to standard and just have that refresher for the healthcare staff. So prior to going to India, I received my certification as a basic life support instructor. And I did that here in the US through the American Heart Association. And then I went to India and I conducted a couple of sessions and classes for the support staff and the nurses there. And then the last projects that I conducted were the CPR and first aid at the Viveka School of Excellence. So we taught CPR and first aid to students in grades 11 and 12, and then we taught just first aid to students in grades 6 through 10. So the main reason behind this was to provide exposure and empower kids from a young age, that if there is an emergency, they should be proactive and, take the initiative to act. So we gave kids the opportunity to interact, learn, and then ask questions, and it was pretty well received overall.
All right, so now we're going to get into my project. I did not have as many as Eesha. I don't know how she got all of hers done. She was very, very motivated. So my project looked at understanding disease prevalence in these tribal communities. I was looking at communicable and non-communicable diseases, and I had to break these up into these two just because it's more important to kind of understand, is it more of an infectious disease problem or is it more of a chronic disease problem? So the focus that we were looking at was disease, gender, age, month, and village. We were really interested in seeing how these diseases were affecting these geographical areas, at what times of the year, which age groups were more affected than others, which gender was being more affected, of course, and then of course, whatever diseases were being reported. How I did this, lots of Excel spreadsheets. I created over 400 graphs. It took me the entire 8 weeks that we were there. I'm not going to show them all to you to spare you your sanity and time. So just to talk about these pictures really quick, the top one is a community health worker doing a hemoglobin blood test, which Eesha talked about earlier, looking for at anemia. malnutrition is a really big deal and a problem in this area. And so this was actually the very first test with this new blood test machine that they had that day. So I got to document it, which was really cool. On the bottom picture, there's a doctor giving a baby an immunization. I like to joke, how many hands does it take to vaccinate a baby? There's lots of hands there. But these are all community health workers, and of course the mother is holding the child, and I was just told to stand back. So I did. So my results. These are the non-communicable results here. If you'll look, the very, very tall red bar on the far left, that is gastritis, also known as acid reflux or heartburn. Very, very common, something that we experience here. One thing to note is there were over 8,000 reports of all of these diseases, and so you can imagine I hate eight months worth of material to go through, and this is why it took so long. And so one thing to note about this gastritis is some possible causes are the malnutrition, eating very spicy foods, which you enjoyed today, and they're much spicier over there. And this is an opportunity to potentially look at some lifestyle modifications that we may encourage, having a more balanced diet, maybe putting a little bit less spice. So those are some prevention measures. This is very easily treatable with medication, and this is something that I saw was given out like candy. They were giving medication to treat this because pretty much everybody who came in was talking about a stomachache, and so that's why this is so high. On the far right, I don't want to ignore this data. These things are reports like cough, headache, body pain. These are not things that are diagnosable. They're not diseases, but they're very important to consider because they're called secondary symptoms, and we use these reports to make the diagnosis. The other reason why this is important is because it helps us understand the perception of disease in this area. How are they explaining their symptoms? How are they talking about disease? Because they're not going to come in and say, I have heartburn. They're going to say, my stomach really hurts, my esophagus hurts, or my throat hurts. And so these types of information is really important to consider whenever we're trying to understand perception of disease in these areas. So these are communicable diseases, also known as infectious diseases. And again, on the far left, that giant blue bar, that is upper respiratory tract infections. A lot of these things are viral in nature. They cannot be cured per se, but they do require supportive care. And by that I mean Advil for body pain, Tylenol for fever reduction, cough drops if you have a cough. And so these types of things are important to have in the mobile health unit. The reason why we wanted to look at this was to understand how to stock the mobile health unit so that we have enough medication. And so this was really important to consider as well.
So the school health screenings were projects that Ashleigh and I both had the opportunity to participate in together, and they took place over a 2-week span, and they were at the Vivica School of Excellence. The main audience, or the people that we saw, were kids aged 3 to 18, and the main purpose was to conduct just a screening to see if they were doing okay. So what we did was we collected their vitals, which includes blood pressure readings, respiratory rates, height, weight, and then a physical was conducted as well as a basic eyesight screening. And if anything was out of order, referrals could be made. And the school screenings were conducted by interns from the U.S. like Ashleigh and I, and other medical interns from India and the U.S., as well as support staff. Alrighty. So these pictures up here are all about my experience in India, and just a couple of memories I really wanted to share. So the picture on the left over here is from a Hindu temple visit. So this was during a field visit. We went to one of the villages, and on the way back, we had the opportunity to stop at a Hindu temple, and I was very amazed by how well it was preserved, how beautiful and breathtaking it was, and I just really wanted to capture it in a picture. The middle picture is from World Earth Day. So we were taken to a local school in Surgur with a couple of the doctors and a few of the other interns from the US, and we helped plant trees and just shed light on the importance of preserving the environment. And then the last picture on the far right is from one of my basic life support workshops. I was teaching the hospital staff how to properly oxygenate a patient.
All right, and these are some of my cultural experiences. So the top left photo is from the same Hindu temple that Eesha was talking about. But these are all of the interns that we were working with. All of these interns are from the United States. There are a couple of community health workers and then our mentor as well. And so we actually were going on a health visit during this visit, and so we made a stop. We just kind of pulled over to the side and went to this temple, and it was a really interesting experience. I've never seen anything like this before. The architecture was amazing, and I just had a really great cultural perspective moment while I was there. On the bottom left, we were in Mysore. This was the first full day that we were in Mysore. So before we started our projects, we got to visit a college of pharmacy in this city. I think there's 3 different colleges of pharmacy, but we got to go with this one. Pharmacy is very different in India. 80% of the graduates go into industry with drug development, which is very different from the United States. Here, we focus more on clinical work, working in community pharmacies and hospitals and the like. So it was really interesting to get that different perspective. They had lots of research labs there, and they even had a garden where the plants that they would use to make these drugs, and they would have tests to see if you could know all the plants, and they were required to know this, which we do not get that type of education here, so it was really fun to kind of see that. And all the people that are in this picture are all the staff from the College of Pharmacy, and also their principal. On the top right, we got to participate in International Yoga Day with the SUIM staff and other interns. So we went into this big pavilion. They put out this giant blanket, and it was a huge blanket, and there were probably about 100 of us there. And they did yoga in the local language, which is Kannada. And so I had no idea what was being said. I was just watching the people around me. And I also learned that it's not just me that's not flexible. People around the world are not flexible. But it was a really fun experience. This was after we were done. You can see the sheen of sweat. It's harder than you think. So that was a really great experience. On the bottom right, this was the last day that we were in Sauragor. SUIM likes to do a presentation day with all the interns. And so they pretty much required us to wear saris, which I'm not complaining, but it is really hard to wrap. And I respect the women that wear these every single day. It took us over an hour, and that had 3 other people around us. So that was fun. Needless to say, I did not unwrap that thing. It is still wrapped, and it's up in a suitcase because I don't want to lose all that. But anyway, so that was a really good experience. We got to tell them about what we did within our internship, very much like what we're doing right now. But they understand all the cultural things, so we got to go into more detail on some fun stuff. So, lessons learned. On the far left, this is a very interesting picture. It's a very unusual experience. My feet are in a tank of fish. And so this tank, they call them fishy pedicures. And so these fish like to nibble on your feet with and take the dead skin off. It feels really great, you guys, but it's kind of weird when a fish gets in between your toes. But this is just sitting, this was at the Mall of Mysore, and people can just come up and they just put their feet in for 15 minutes and then they leave and they go about their day. And so this was a really unique cultural experience. Very, very strange feeling, but I really enjoyed it. The person on the right to the right doesn't quite feel the same way, but it was really fun. It was cool to see, and I'm telling you, my feet felt great. The middle picture is probably my favorite picture I took in India. I was out on the mobile health unit in the forest, and the doctor just said, "Hey, Ashleigh, there's a bird in that tree." And I didn't really think much of it, but then I saw it was a parrot, which is not something you see here on a normal basis. And so I just snapped this picture, and it kind of made me realize the tribal people live in this beautiful environment every single day. And it just really made me appreciate and respect their culture and lifestyle. And it kind of gave me a better perspective on how we can work with these people and provide these services that they need. And so that was just a really good experience. On the far right, these are all the Indian interns that we were working with. If you notice, I'm the only white person there, so that was really fun. All of these Indian interns are from all over the state and also all over the country. And I still talk to these people every day. One of them just messaged me a couple hours ago and asked me how I'm doing. And these people gave me a really great experience at what our generation is doing worldwide. So they're still dealing with the same things that we deal with here, and they still get into Facebook fights, and they're still on Snapchat. And so these cultural experiences were really, really great, and they're still teaching me about their culture, and I have a better appreciation for Bollywood, for sure. Those movies are very long, but it was a really great experience. I really, really enjoyed it. These people changed my entire perception of Indian culture, and I just really love these people, and I hope that I can go back and see them again.
These are some of the lessons learned and memories that I made. So as you can see, the picture on the left and the right are with some of the kids I met during the school health screenings, and just during my free time, I loved the school in the backyard of the hospital, so I used to try to go to their playground, although I'm a little too old for that, but I used to go to their playground and just try to interact with the kids. Ashleigh and I got to sit in a couple of cricket games, and she played. I just watched from the sidelines, didn't want to hurt anyone, but I really had the opportunity to interact with people from all walks of life, from, all demographics, different ages, and it really made me appreciate everyone and all the memories that I made. I learned so many different lessons directly and indirectly, some of which were just to smile more, to live more. So I am very appreciative, even from the little kids, to, learn things like that. And then the picture in the middle, so this picture has a very interesting backstory. I was on the mobile health unit for my projects, and it was on a Friday. This village was located in a tiger reserve, so the people in this village have no connection to the outside world, in the sense that there's no electricity, there is no network. They're very in their own, bubble, sort of. So I went in, and all the doctors in the team were walking right by me, and I kind of went to the back of this person's house, and that's their backyard. There's a little man-made gate, if you can see it, like just, the little woods and little logs and trees. And then if you open that gate, there's a bunch of trees that, go as high as you can see. So it was a wonderful picture just to be there. I took a step back, and I was just mesmerized and in awe of the beauty of it all. And it really made me take it in and wonder, like, wow, this is a great feeling to be here. Appreciate what you have, and learn to, just take a step back and be grateful. So like Ashleigh said, we were exposed to this and had the opportunity through this internship to go there, but this is the villagers and the tribal people's life every day. So that was something to consider. And lastly, we would like to thank all of our supporters, so the South Asian Studies Program and the Ananthamurthy South Asian Endowment, as well as the Kenneth J. Camille Internship Program.
I would like to thank the Stanley UI Foundation Support Organization for their funding and support. And then we would also like to thank the Global Health Studies Program, because without them, this project wouldn't have even been possible. And what questions do you have?
A good practical question. What did you learn that you will apply to your future pharmacy work? You can both answer that.
So this is something I actually learned. I had this conversation with one of the physicians over there, and it's to go with your gut. To really not second guess yourself, to listen to the patient and then go with your gut. And I appreciated his advice. Sometimes we overthink, so he told me not to do that and just learn to listen to what they're saying and then apply your knowledge without overthinking.
I learned a lot about cultural perception and beliefs and behaviors while I was there. And so that's something that sometimes we as healthcare professionals forget about. We think about, okay, we need to treat with this drug and we need to do this now. But we sometimes forget to ask the patients what they think and what they want. And I learned that a lot working with the tribal populations and with the doctors. That perception, understanding those behaviors and beliefs are really the difference between a good healthcare professional and a great one.
Okay. Another rather practical question. Was language ever a problem?
For me, yes. Eesha knows Hindi, and so she was able to kind of talk in a different way. However, we were very, very lucky. One of the other interns knew the language. She actually was born there. And so if we ever needed a translator, we would just ask her to come with us. Most of the time, all the doctors can speak English, and so if we need something translated with a patient or with someone in the tribal community, it was pretty easy. However, it would have been nice to have been able to understand the language. And we did a little bit of basic language preparation before coming, and so we had a few words here and there, but obviously not the conversational level that we could have had.
As Ashleigh said, we did learn a couple of words and phrases here and there. Some of the common phrases I knew was fever and a little and a lot, and then my food. So it was always interesting when a patient would describe what they were feeling, and I would pick up a couple of words, but then that was it. And then my follow-up question would always be, fever, like, do you have a fever? And they'd say yes, and then that was it for me. But it was a great learning experience.
Okay, a question about the tribal environment that you were in. What observations do you have about the forest people's transition to agriculture? Did that seem to be now an established part of their culture?
The ones who live out on the edges of the forest, that's part of their life now. As far as we could see, much of what we were learning through the doctors and through the community health workers, and so we didn't actually get to have those direct conversations with the tribal peoples because they were out in the fields, and we can't ask them to come in to talk to us about that. But I would say that they have been able to make that transition for the most part. There are still some tribal communities that refuse to leave, and so they're on the inside of the forest, and they don't practice those agricultural things, and so it's really hard to say what they're doing, and we heard some different things that they're doing, but unless we actually have those conversations, it's really difficult for us to make that assumption.
Okay, some specific questions. How are expenses for specialist referrals covered?
So the government subsidizes a lot of care. For example, with TB and HIV/AIDS, there are a lot of government subsidized programs because those do necessitate specialized care. So a lot of it is actually free or very highly subsidized. And then for other disease states that the government doesn't have programs for, they're as well subsidized. The hospital system, as an example, provided very highly subsidized care, and they had specialists there too that visited like once a month or twice a month.
Okay, so now here's something a little more controversial. There are those that consider words such as tribe and tribal as pejoratives, implying primitive or backwards. Would not ethnic groups be preferable? Do you want to talk about the use of tribal? Because there are reasons for it.
Sure. Yes. So, I understand what the author of the question is saying. We were taught when we were there throughout our internship by the directors of the program and the doctors that they prefer being called tribal populations. I mean, not the term in English, but its translation as well, because that's all they've known. So that is how we refer to them as well. Yeah.
Eesha mentioned documenting code procedures and indicating what should ideally be done. How did people who are older and perhaps more experienced react to being told what they should be doing by a young person from the outside? Good luck.
I was actually worried about the same thing, especially since I'm a young person from outside that is female. I had some hesitant feelings here and there, but my supervisor was amazing, and he really respected what I had to say and contribute. And, I asked him, do you have anything that's differentiating that you would like me to incorporate as a note throughout my workshops? And he said, no, you are the expert. You took a class. I appreciate that. And that's how I dealt with that.
Okay, some real specifics now. Question for Ashleigh. What were the findings related to age and gender in your study?
Sure. So the age breakdown, we did the pediatric populations, we did like 20 to 45, and then the geriatric populations. And of course, that 20 to 45 range is where most of the people are going to make those types of reports. And so there were some specific things that children were experiencing, but I would say it was the young adults to the mid-life where they were experiencing most of that. Also, about 62% of the reports were made by women. You can make whatever you want from that. Either women are more likely to make those types of reports than men, or they really are experiencing more things than men. It's hard to say. I wasn't able to get that deeply into it. I was just able to look at the retrospective data analysis of this data that they'd already collected.
Okay, and still for you, Ashleigh, what role is played by Heliobacter species in the observed gastritis?
Fantastic question. Not sure if I know the answer to that one. We were not looking at the causes. We were just looking at the prevalence. The causes, that's a study for another day, and I hope that that's something that they will look into in addition to the data that I analyzed.
And yet again, Ashleigh, some reports have associated anemia with ringworm infections due to people working barefoot. Have you seen this connection?
Again, I don't know about the connection just off the top of my head. I was just looking at this data that was collected. These are some really good questions, and I'm probably going to email my mentor when I get back with these questions for something that he can think about as well.
And for both of you, what hospitals are available for those situations that the mobile unit can't handle?
So their main referrals they send into Saragor at the Vivekananda Memorial Hospital. If they can't take care of it there, they send them into Mysore. There's a couple of high specialty hospitals in Mysore, and there were a couple of times that they would bring a patient in. For example, one was in a car accident and they had some head trauma. We can't take care of that in Saragor, and so they loaded up into the ambulance and they sent them into one of the hospitals. There's actually just a hospital a block away from the headquarters in Mysore, so that was really convenient.
And some broader questions. Is this the start of a longer-term initiative for the College of Pharmacy or for you both personally?
So hopefully it is the start of something larger for the College of Pharmacy. As the PharmD program is something relatively new in India. It's only 10 years new in India, and over here it's been around for longer. The transition is kind of, they're still catching up, to where we are over here, but we are hoping to keep that relationship going through sending students there and just through keeping up, seeing what they need, and just, having a positive relationship with them.
Yeah, for me personally, I plan on continuing to work with this organization. Additionally, I would also like to be part of taking those students from this College of Pharmacy over there. This is, I think, the first time that the College of Pharmacy has ever sent students to this area, specifically working with SVYM. And so, as Eesha said, we would like to continue this relationship, and I think we both would like to be part of that continuing in and of itself.
This is a more specific one. Did you develop an appreciation for Ayurvedic medicine?
I already had an appreciation that was existing, thank you to my mother. My mom has been born and raised in India, so coming here, that's all. Tylenol and ibuprofen were always off limits for us unless we actually had something serious. So I had an appreciation, but going there and learning the reasoning behind it really opened up my eyes, because when I asked my mother questions as to why, she would just say, because, and to a growing mind, that's not always enough. So I really appreciated having the opportunity to ask these questions and then have the science behind them explained to me.
For me, I had never had any previous experience with Ayurveda, especially growing up in a very Western country. Sometimes we look down on it, and I think that's out of ignorance. And so I got so excited about it that one of the Indian interns, I would ask him to do one of his checks on me, and it's like you check your pulse and it tells you all these different things. And I think I asked him every day, and he got to the point where he was so tired of it. He was just like, Ashleigh, stop. You already know the answer. And so I just wanted to know. But it was a really exciting, we got to tour the research area in Kanchanhalli, and so I really liked it. I have a better appreciation for it, and I think it's something that as pharmacists we can incorporate into our practice here as well.
Okay, this is the final, but perhaps the biggest question. What did you learn about yourselves through this experience?
Okay. This one's tough. I think I learned that I don't know as much as I think I do. I had been to other countries and done other research projects and service work, and so I see myself as decently well-traveled. But until you go to a country like India, you really have no idea what you're getting yourself into. And so I learned that I need to take a step back. And even though I'm trying to practice that cultural humility, even when I'm trying to practice that, sometimes I mess up. And sometimes I'm making assumptions that I don't need to be making, or jumping to conclusions, thinking that I understand a culture that I've only been in for a couple of weeks. And so I think that was probably my biggest thing. And thank the Lord that I had Eesha with me, because even when I tried to be responsive and humble, she's like, no, we don't do that here. And so that was a really good experience. And I think that I wouldn't have been so receptive and that additional, humility without Eesha.
So what I learned the most was to be open to new ideas and just to be open, have an open mind that is open to learning new things and other perspectives. India just was a very unique and different experience, and I don't even know how to begin answering that question, but I think that's the biggest thing that I learned about myself.
Okay, thank you. Those are great questions, good answers. We conclude our program. I want to give a big thank you to Ashleigh and Eesha. I also want to thank our sponsors, University of Iowa's International Programs, University of Iowa Honors Program, University of Iowa Public Policy Center, and the Stanley UI Foundation Support Organization for their generous support. And then today's special sponsors, Mason K. Braverman, Mike Carberry, and City Channel 4 for making these available for viewing. Ashleigh and Eesha, this is the special presentation. As a token of our appreciation, we present you with our coveted Iowa City Foreign Relations Council mug. And indeed, there are two of them. Thank you. Thank you. We are adjourned.